happy to have Jennifer Bowman, who is a registered nurse. She's been in nursing since 1991, and for the past 12 years has made hospice sort of an area of clinical focus, and the last 3 added on palliative care in addition to hospice. So we're interested to learn a lot more about palliative care tonight. Jennifer splits your time between working for hospice and needs a medical center as a palliative care coordinator. So I'll turn it all over to you for you to give us the insight that we all need.
Okay, well, thank you.
Thank you for coming.
So when I talk to people, it's always interactive. And I expect you to ask questions and pipe up whenever, because you're not going to learn if you don't ask the questions. And I talk about this subject a lot to Allegheny students, to people in the community, to people in the hospital, and all that. Who knows what palliative care is, or who has an idea of what they think it is? How many think it's the same as hospice care? Okay, good, good. No preconceived ideas here. Hospice care is separate, but overlaps with palliative care in that hospice care is strictly end of life. Palliative care can happen at any time during your life. In fact, if you have taken a Tylenol or an Excedrin for a headache, that is a palliative measure. It's treating physical symptoms and a lot of other things too. So when I typically meet with families to talk about issues, when I get a palliative care consultation, what I really do is get a feel for what they already know about what's going on in their bodies. We all own our bodies, but a lot of times we really don't have a good understanding of what's going on inside of them and why what we're seeing is manifesting itself in the way that it is. A lot of times people come into the hospital over and over and over with the same complaints that are not really being addressed. And that's where palliative care comes into play. Palliative care can happen at any time if you are doing chemotherapy, if you're doing dialysis, if you are just newly diagnosed. And what it does is to tell you about what your body is doing. It tells you how your body is working and how the different diseases that you might have in your body interrelate and how it is affecting your overall state of health. So we talk about, when I see people typically, they're already in the hospital. They may have been in a few times. That might be a new diagnosis to them. But I get a palliative care referral. And really, when I talk to people and their families, the more the merrier. Because, you know, when you're faced with a disease, maybe a new diagnosis of cancer, or you've been in and out of the hospital with kidney issues or lung issues, heart issues, it's too much to absorb to think that this might be towards the end of that disease process. And everybody, no matter who you are, is going to die of something. So even if it's dementia or Lou Gehrig's or whatever, we know eventually that's going to take your life. Now, what palliative care does is explain what you're seeing in your body day to day, and also let you know and can anticipate things that you will see in the future before it becomes a crisis situation. For instance, lots of times I talk to people with lung diseases, and I can tell them, based on what I know about your lung disease and how it will progress, how we expect the natural progression of this disease to be, or heart, or whatever disease that you have, the natural expected progression, this is the choices you'll be expected to make in the future. Now, if you have a heads up about lung disease, for instance, we know you will have recurrent infections, pneumonias, things like that. We know that you may be on the ventilator, off the ventilator. Eventually your body won't be able to breathe on its own. This might be years down the road, but you need to know and be able to think about and talk about with your families what you would want to happen when that time comes when you're not able to be off the ventilator any longer. And there's several options, and that's what I help families to explore in these conversations, to talk about things that would happen down the road. And sometimes these referrals come very late in the disease process. So when I'm talking to families, it can be when this person has already been on the ventilator several times, and they're looking at maybe having to have a tracheostomy or a feeding tube, because they kind of go hand in hand in nursing home placement. And a lot of times, they don't understand that and what the implications are in their day-to-day life and the decisions they're being asked to make. And that's a large part of what palliative care does. It manages physical symptoms, certainly, but it also takes into account that individual's disease process and other things that are going on. That's called comorbidities. If somebody has lung disease, they might also have diabetes. They might also have high blood pressure. They could have a lot of little other things going on that really affects their total state of health. And putting all those pieces together is what palliative care does, as well as managing the symptoms of what they're seeing day to day. So when we talk about their disease, their current state of health, and things that they'll have to anticipate, decisions they'll have to make, that family and that person really can make the best decisions of what makes sense to them based on what they want their quality of life to be day to day. Another example is people with dementia. I certainly know that people with dementia, eventually, as this disease progresses, they'll have swallowing difficulties. They'll have trouble walking, feeding themselves, bathing themselves. I know that they will have recurrent infections, bladder infections because of incontinence. If they're not swallowing so well, I know that they will have pneumonias, recurrent pneumonias, those kinds of things. And it's just a big picture that the disease is progressing, and it's evidence that people can see day to day that things are progressing. So things that families will have to decide about these people with dementia, because at this point they're not able to make medical decisions for themselves anymore. And a lot of people really shy away from planning ahead, like the what ifs type of thing. Some people do advance directives. Some families follow them, some do not. But one thing that the families need to know, and that I talk about, is what dementia is, how it affects the body, and what it presents like in the brain. I can show actual pictures that, of the progression of it, but decisions that they'll have to make is whether you want a feeding tube. When they can't really swallow safely on their own anymore, and they don't know you, and they're weak, and they have recurrent infections, what do you want to do the next time they have an infection? What do you want to do this time they have an infection? Certainly antibiotics are effective, but we know this is going to happen again. And palliative care helps to sort out those issues for families to make sense sometimes, to know when enough is enough. And just because we have that technology, really we can almost artificially keep people alive indefinitely sometimes. Is that what you want your quality of life to be? Is that what you want your loved one's quality of life to be? So issues that people with family members with dementia are faced with is a feeding tube. What's that going to do? It really prolongs the inevitable. And allowing those families to cope with these issues in advance of, your mom has had aspiration pneumonia now 6 times in a row. She's failed swallowing tests over and over. She just keeps choking on things. What are we going to do? And sometimes families just need that reassurance to know it is not mean to say enough is enough. We all have to die from something, and the people that I talk to just happen to have a heads up of what it is it's going to take them in the end. And maybe not today. It could be 10 years down the road. Palliative care really is most effective the earlier that it is introduced, and here's why. Because if you have respiratory problems or heart problems, and you are in and out of the hospital, palliative care really manages physical symptoms day to day So you are not having physical symptoms that are so out of control that it necessitates a hospital stay. You're being more managed day to day, which improves your overall quality of life. You're home more. You're able to do your thing. You're getting more education. Your family's getting that support. So overall, it really increases the value of your life and people's reported value of their life. Some of the symptoms that are managed with palliative care are pain, shortness of breath, anxiety, nausea, vomiting, constipation, even insomnia, things like that. Anything that really can bother anybody, something can be done about it while you're still continuing to get aggressive treatments for whatever disease you have. It doesn't necessarily mean that you are end of life if you have palliative care involved with your care. And Crawford County, this part of the state, really is kind of slow to accept changes and things like that. But I can tell you in the eastern part of the state, in other more urban areas, palliative care is seen as a very valuable asset in reducing hospital admissions, emergency room visits, unplanned doctor visits, because of the interventions that they propose all along. When people know what to expect, what's normal in the course of their disease, they're not as frightened by it, which means that they're not going to see the doctor because something new has changed. They have a heads up. They know what to expect. They know when you get weaker, when you're sleeping more, when you're eating less. All of these are very normal changes that we expect to see in the progression of any disease. So when we talk about the expected natural progression of a disease, that's what we mean. And it really decreases the fear value of what people are experiencing. And they know, because they've already talked, in theory, to their palliative care person, what plans they would want to make as these changes occur in their lives. They've already come to the conclusion, I would want a feeding tube. I would not want a feeding tube, because they already know what changes and how that's going to affect their day-to-day life. And really, palliative care enables patients and their families. It empowers them. They feel like they're being active participants in their care day to day, their medical care over several years' time, rather than being acted upon, because they are educated and they know exactly what they're dealing with. They know if they have liver disease, they know how the liver affects the heart, affects the circulatory system, all of that stuff. If people have heart disease, they know exactly why what they're seeing is affected by the kidneys and everything else too. When their legs swell, it's normal. They're not as frightened. They might be a little dismayed that their disease has progressed, but they also know this is exactly what is going to come to pass. They know they're going to be more tired. They know they're going to have poor activity tolerance. They know they might need oxygen down the road. They know they're going to need more assistance day to day. And that can be the same with any disease process. And another thing that palliative care helps with, when doctors go in to talk to patients, and when I see them, it's predominantly in the hospital, they spit out this medical jargon that really people don't understand day to day. If they're not medical, you don't understand. People don't want to appear stupid. They don't want to take up time. They listen to this stuff coming at them. Sometimes they're alone and they have nobody to ask questions, write down things, or interpret. And that's what palliative care really can do. It interprets the medical jargon, what they're hearing, to the level that they're able to understand. If they're able to understand, then they're able to make the best medical care decisions that make sense to them. Another thing that palliative care offers is the availability of time. Sometimes these conversations can take an hour, hour and a half initially. And then the follow-up conversations also, because it is just too much to absorb at any given time. You're telling me about my disease, you're telling me about my body, you're telling me things I might have to consider in the future, and it really needs to be broken up into bits. It takes a lot of years really to develop a disease to the point that you are dying from it. And ideally, I'm seeing somebody well in advance of that. But still, you've lived with this disease a long time. You've already had to make some decisions, sometimes in a crisis, sometimes not. But having that heads up of things that is coming in the future is very, very important for people. It is very accommodating to them, and they're able to make the best decisions of what makes sense to them. And that's a lot of what palliative care is, really aligning the treatment options that are available to people based on their disease processes, more than one, and most times people have more than one thing going on. Really, one thing is the thing that is the most predominant, but other things factor into that too. But when you're offered treatments, sometimes people really don't know. If they don't know what the side effects of chemo might be, if they have cancer that's spread all through their body and really can't be cured, do you want the chemo? Do you want the radiation? What's your life going to be like? What's it going to be like? And lots of times I talk to families about questions to ask their doctors when they go in there. Is the treatment that you're proposing to me going to cure me? And if it's not, does it make sense to me to do something that might be futile, that might be just seen as going through the motions? Sometimes people say, yeah, I'll do anything I can for that small chance. Some people say, I've heard about those treatments. I've already been through those treatments sometimes. That's not for me. If it's not going to cure me, why go through the effort? I'd rather be more comfortable and have a higher quality of life day to day and do things that are important to me. Palliative care in the hospital is also interdisciplinary, which means there's a lot of different people that assist in these conversations if it's needed. We can have the family physician be there, the hospitalist who sees the patient day to day, any specialists that are available. If speech therapy needs to come in and really present what they're seeing, social services certainly is there to help make decisions of what's going to happen and what's the best options for when they go home. The patient's nurse that is taking care of them day to day is often there to present a really accurate picture of how much help this person needs and what they're like when their family's not there. Sometimes people really spruce up when their families come in and put on a false picture. And if somebody was sent home like that, the family's really going to be overwhelmed. And so after we would have these conversations with all these other entities there, I help to sort out what that really means to them day to day. Lots of times those conversations are filled with reminiscing about stories when they were well. Sometimes they're just so totally overwhelmed of thinking what they might have to think about, what they might have to decide. A lot of it is just venting, allowing people just to express their feelings. Sometimes the decisions that families are asked to make, they really feel guilty about. If somebody needs to be taken off of a ventilator because they know dad did not ever want to have a trach, the hole in the throat to breathe for them, or a feeding tube, or be in a nursing home. And when they're faced with that decision, it's really overwhelming. Certainly support them in what the patient would have wanted, but really to align what that life would be like. You know, it's not that you wish this person to be gone, but you certainly don't wish them to be like they are, and the patient wouldn't want to be like they would be if these interventions were in place. Some treatment options for now. Do you want antibiotics now? Very simple. Most people say yes, of course I would. Who would not? You know, we have that. Treatment options for in the future. If your heart would stop, we know you have a bad heart. We know it is really fragile in there and you have a lot of other things going on. If your mom's heart should stop, do you want CPR done? Well, of course. I hear, until you explain what CPR really is. It's not like on TV. And people think that it is this very kind thing that you get shocked a couple times and later that day you're talking on the phone with your friend drinking a cup of coffee. When people hear an accurate description of the treatment interventions that are being proposed, like CPR, they most of the time change their mind because they know it is not, sometimes they're not kind interventions. They're interventions designed to extend life, to save life. But what's your life after that? I'll give you an example. I had a patient with pneumonia who was getting better. And the pulmonologist, the lung doctor, came in and saw that person and said, I can get them over this pneumonia. I said, I know you certainly can. However, this person also has 2 different sites of cancer that they're dying from. The family chooses to take them off of the ventilator rather than to suffer more. You know, it's just those kind of things is what palliative care allows the family to help sort through and gives them that support rather than to have to make decisions off the handle without really having any information, without having any emotional support. Palliative care also offers spiritual support too. That's a really big component for some people. They find that a big comfort. So what I really do is to put the pieces together for people. If you have a lung specialist, a heart specialist, a wound specialist, they're all just interested in their own little area, their own little expertise. Palliative care helps to put that whole picture together and what that means and say, this is going on system by system by system in the body and how it all interrelates and how it all affects their life, their quality of life, their day-to-day life, their future quality of life. And a lot of people really say, nobody takes the time to do that. You know, for one thing, the doctors don't have a lot of time. They're seeing how many patients a day. They have other commitments, things like that. But if somebody is in the hospital and I can follow them for several days, they have an opportunity to hear the initial news from the meeting. I always tell them, if you have questions, and I know you will think of them, write them down because you won't remember them. It's just too overwhelming. And I'll see you tomorrow. And they always have questions, and they always want to know more because people want to know what they're dealing with. It's always has seemed kind of mean to me to ask patients and their families to make decisions about somebody's care without having all the information. If you don't have all that information, how are you going to make the best decision? And then you're always second guessing yourself. If you have all of that information about disease process, about how your body works, about things you're asked to decide, the implication of those decisions, what it will mean to you, then people have peace. Whether they decide to have aggressive treatments, and if it's very early on, then they certainly do, you know, good. You still have a long life ahead of you, but here's what you have in store for you. Here's what we expect to see. Here's what you're going to expect to talk about and decide about. So some of the things that people do on their own, and sometimes with their physician, is to do some planning for when they're not able to make those decisions or why those decisions are still hypothetical. And you might have heard some of these things besides palliative care, and some things that are similar to that are advanced illness services, advanced illness planning. All of those things are very similar. A lot of insurance companies call them different names, but it really amounts to the same thing. You're told about your disease, you're told what decisions you'll have to make, and you can start to make some plans with your family. How many people here have advanced directives already? Who doesn't know what advanced directives are? Okay. Advanced directives is a document that speaks for you if you're not able to on your own. It clearly outlines, in the event of your heart stopping, not able to breathe, you need dialysis, you need artificial feeding, you need all these different things, would you want that? And that really takes a lot of thought for people. If you're feeling well, and it's really not an issue right now, but it really helps the families when that time comes, when you're not able to speak for yourself. If you're still coherent, you still have your wits about you, you're still able to make rational decisions, certainly you are the first one that people will ask about your care. But if you're on a ventilator, if you get dementia, if you really are not able to speak for yourself, this document guides your families in what you would have wanted to be done, which I cannot tell you how many times people have said, I'm just, thank God my mom did that. I don't have to try to read her mind. I don't have to try to guess what she would have wanted. And it's very, very clear. Other things that go along the same lines that you might see in the hospital is a pulse form. This is something that nursing homes like to have, ambulance services like to have, and it really outlines it but condenses the same type of information. It asks if you want CPR during transport, if your heart should stop. And these are people that are sometimes in precarious health conditions, but still it could be anybody. Ambulances want to know. And unless it's very clearly stated, they are obligated by law to do those interventions to you. If you say, oh, I would never want CPR, when my heart stops, my time's my time. Unless you have it spelled out and you're in an ambulance, they have to do it. If you were to drop over at Walmart and your heart would stop, people would attempt to resuscitate you. It also asks if you would want limited interventions, comfort measures, antibiotics, artificial hydration or nutrition, which would be an IV or feeding tube, sometimes through the nose, sometimes through the stomach. And it also asks who you talk to about this. If somebody has Alzheimer's or dementia, I really can't discuss those issues with them, but hopefully they would have designated a medical power of attorney. Does everybody know what a medical power of attorney is? Who does not? Okay, good. You know that's different from a financial power of attorney. Another thing that they can use in the home is 5 wishes. It's a document that people can kind of peruse at their own leisure. It asks who their healthcare agent is, someone to make decisions for them. It asks things about what they would or would not want to have. What life support means to me. What does that mean? Some people, it's gung-ho. They want everything. Some people, it means absolutely nothing. And everything towards palliative care is really designed to align medical care to what the family and what the patient wants. Conditions under which I do not wish to be kept alive. I mean, this is really comprehensive, but it is a document, that people can fill out. And sometimes when people are battling a disease, or if they're in the end stages of the disease, they feel like they have no control over their life. Just imagine that you have lung disease. And breathing is an effort. You're on oxygen. And those people we know are going to conserve energy because their skeletal muscles take so much oxygen, it's just easier for them to sit. They have poor activity tolerance. They're not eating as well because eating takes oxygen. It's just too much effort. Talking takes oxygen. And pretty much that's where they are. All the things that they used to take for granted that they could do, get up to putter around, go outside, go for a drive, visit with people, talk on the phone, really is too much effort now. It's physically exhausting. This is one way for people to really still have some control over what happens to them day to day. Palliative care increases the dignity of people's lives because it empowers them. In the hospital, over the past year, it's really started to be more accepted because it's seen more as a resource to the physicians, to the nurses, because the nurses are there every day. They're seeing these people in and out. They're spending time with them. They know sometimes there's symptoms that are not managed as well as what they could be. And with palliative care, the symptoms are managed prior to discharge. And multiple studies have shown with just this simple intervention, hospital readmissions are decreased. ER visits are decreased. Unplanned doctor visits are decreased. Hospital length of stays are shorter. People often opt to not have unnecessary lab work or radiological testing. And if you really look at the future, with baby boomers coming up with their chronic diseases, just this simple intervention really socially is going to make a difference. And plus, people are having the care that they desire day to day. It's not being forced on them. They're not being coerced. They're not doing it because they don't understand what's going on. So it really improves the continuity of patients' care. When continuity of care is something that occurs over a lifespan. It can start from the cradle and go to the grave, and it really overlaps. You have a pediatrician, go to your regular doctor, the specialist, and all those things really overlap, but palliative care during a disease process can help all those pieces come together. Earlier referrals or consultations to palliative care manages symptoms day to day, and how it decreases hospital stays and the ER visits and doctor visits is because those symptoms are managed better. Think of this. You have chronic pain from cancer. You're getting treatments, which is cool. You're doing your thing, trying to get better. And on Friday afternoon, your pain is getting worse. And you really don't want to go to the ER because you know they're going to keep you and you just want to be home doing your thing. You got something coming up this weekend, or it's going to be a nice weekend, or you just don't want to be there anymore. You're sick of doctor's offices. So the doctor's office is closed, so you figure you'll tough it out until Monday and call in and get an appointment to see what they can do for your pain. So you call Monday and they have an opening Tuesday, or maybe late Monday, or maybe later in the week. So meanwhile, how long have you suffered unnecessarily? And it could be the same for nausea, it could be the same for shortness of breath, it could be the same for any symptom. Palliative care alleviates, when it's used properly, can alleviate those swings of symptoms, which often necessitate in a hospitalization. And that's how it improves day-to-day life. If you're feeling better because you are being more managed than going to the doctor periodically when things get worse, and you see them, or things get worse and you go to the ER, things get worse, you go to the ER and you're hospitalized, often for the same symptom because of your disease, lung problems, we know shortness of breath, heart problems, we know all kinds of things, a lot of swelling, cancer, we know nausea, we know pain. If those things are alleviated, how can that not increase your day-to-day quality of life? And if patients know what to expect, it decreases ER visits, unplanned doctor visits, because we know mom is not going to eat as well as what she used to. It's part of the disease process. It's expected. You're not doing anything wrong. We know this is going to happen. We know she's going to lose weight. We know she's going to be more tired. Do we like it? No. But we know it's going to happen, no matter what is going on. And if families are more prepared, then they understand, and it really decreases the fear factor of what they're seeing. And how that overlaps with hospice care is just more management, more intensive management of the symptoms that they're already experiencing, and emotionally preparing that person for end of life. But really, very simply put, if you have a headache and you take something for it, that is a palliative measure. And lots of times people are very afraid, even medical professionals now, when one of the nurses say, do they need a palliative care referral? Well, they're not ready for that yet. When are you not ready for that? When are you not? When is it too soon to learn about what's going on in your body or what's going to happen to you? That might be 15 years down the road. We don't know. Nobody has a crystal ball. But meanwhile, you're feeling better day to day. And you know. You know what to expect. You know what's in store. You know what decisions you'll have to make. They might not be easy ones, and sometimes those are very difficult conversations for families to have. It's not something you strike up over a dinner table. Hey, if I ever am on a vent 3 times, that's it. I don't want any more, no matter what they say. You know, they're not always easy, and that's why I help facilitate those conversations when they're in the hospital. Palliative care also can be extended as an outpatient basis too. If the doctor orders home health nursing, it's one of the disciplines that can be added to their care at home to help support that person while they are still pursuing aggressive treatment. Or if they really are not, but they're not end of life either, they're kind of in that limbo land. They're still feeling better, that family is supported, and that also adds to the continuity of care that we're able to offer patients. Does anybody have questions, thoughts? Throw it out here. Yeah.
You mentioned several different forms that are available to people to use. Where can they get those?
The Pulse form is available, I know, in the hospital. It's something that we routinely do during a hospice admission in the event somebody would need to go like from the hospital to their home. If they're hospice, really ambulance people are torn. They are geared towards saving lives and doing whatever they need to do. And it really gives them some guidance. I know those are in the hospitals and different doctors' offices also.
So like
The 5 wishes is from the hospice office. Advanced directives, you can go to your attorney to get that filled out.
The other question that I had was, I know you're involved in planning a workshop for this fall in collaboration with hospice and so forth. Can you provide some information on that?
That is a hospice educational symposium. The first one that we had, the guest speaker was Elizabeth Kubler-Ross's son, who was really the pioneer for hospice and palliative care in the 60s and 70s. This year, Dr. Rickard from Allegheny General will be the presenter. And he will talk more about palliative care then. Following will be breakout sessions where people can learn more about different things that interest them. Diabetes education, caring for the caregiver, body mechanics, relaxation. There'll be a drumming demonstration, veterans issues. I mean, it's really a varied topic selection that's offered there that you really can choose a few different things that you would like to learn more about, and that it's possible. Right now, because of Medicare guidelines and contracts and things like that, it can be done. Sometimes, right now, we're doing that as a case by case, and lots of times if people are already in the hospital and that's started, it can be followed as an outpatient. It would not be as intensive because if you're not hospitalized, you don't need that. You don't need someone in your face all the time. So I have a lady that I've been talking to for 3 years now as a palliative measure for her mother with dementia that I see. And it's just that support and predicting things that I know is going to happen and they come to pass. And so she has described it as being very comforting because when she sees it, it's not a surprise, the recurrent infections and things like that. Yeah. Oh, yeah.
I have a couple questions just so I understand this. I believe for hospice care, you need to have a diagnosis for hospice. So would you have to have a diagnosis for palliative care also? And if you weren't in a hospital, would you still qualify for that? Say you didn't have cancer or heart problems, say you just had pain, for example.
Mm-hmm.
How would you go about that?
Well, for hospice care, the bulk of the patients are Medicare aged, and there's very specific Medicare guidelines for every disease process. And it really says, based on your state of health and not pursuing active treatments and everything else that's going on with you, the comorbidities, would your doctor be surprised if you were to die in 6 months? Doesn't mean you have to. We've had people for a couple of years, but would the doctor be surprised? That's really what Medicare is looking for. And other insurance companies have followed suit just because the bulk of the people are Medicare aged. So for outpatient type of symptom management, a lot of physicians really in this area are not referring in any way for palliative care. They feel as though they can manage it themselves. If you were to have specific symptom issues, I would encourage you to call the hospice office because as an outpatient, it's the hospice nurses who are acting as palliative care nurses because hospice nurses are experts at symptom management and this is just an extension of that.
Do you have to be in the hospital
No.
to qualify for palliative care?
No. Anybody can call in with questions.
And do you have to be a resident of Crawford County to qualify for here? What if you lived in Mercer? Would you still have access to here if you have someone you really like a lot or something?
Right.
Do you have to stay in where you
No.
reside?
The nurses that would be making those palliative visits or phone calls, most of the time it just takes a phone call, they go into Erie, Forest, Venango, Warren, Mercer County, as well as all the way up to Ohio, but not into Ohio. See, that's where palliative care and hospice really overlap. Hospice nurses manage symptoms day to day. They educate families about their disease and things that they will see coming up. Not so much treatment options because in order to be hospice, we know you're going to be end of life. We expect that. So you're really opting out of treatments, aggressive treatments at that point. But they're educating the families on what to expect as that person nears the end of their life. Palliative care occurs at any time during a disease process when you're still pursuing active treatments or if you are not at the end stages of your disease. But it also addresses symptom management and education in all of those same areas.
One more question.
Yeah.
Sorry. Say you're not diagnosed with cancer.
Mm-hmm.
But say you just had a lot of back surgeries and you have continual pain. Would you qualify with that, or is that something you go through with PCP and maybe a pain management doctor? I mean,
You would want to do that. Yeah.
Would that all go together?
Well, not really, because if it's not a disease process, if it's like a surgical pain, chronic type of back pain, you would have already been linked up probably with a pain specialist at that time.
So you're
identified as having a terminal result.
No, not at all. You mean for palliative care?
Yeah,
Well, we know eventually we're all going to die of something.
I know.
Yeah.
I mean, if we're coming to you for any of this stuff, then we're looking to have a diagnosis that's leading to that. Not like where she is saying, where the chronic pain is going to debilitate your health, so that's going to make you much more vulnerable for the other things.
Right.
So you have to wait for that vulnerability to happen to connect with you, and somebody else will be managing the other stuff early on.
If you were overall pretty healthy, you pulled your back, got herniated disc, and started that cycle of back surgeries, you would have already have been involved with a pain doctor. You would already have been treating that. What palliative care does is address when people have chronic, ongoing illnesses, whether it's lung, heart, kidney disease, liver, anything like that, that you learn to live with over time, that we know is going to get worse, and based on the other things is going to eventually take your life, but it helps you to deal with that and the symptoms in the meanwhile.
And in palliative care rolls right into hospice,
If the person wants.
obviously.
If they don't. Some people I've talked to said, you know what, it's possible to freeze your head, and that's what I want to do. It's your choice, you know. All I can do is lay out what's going on in an unbiased manner so people can make the best decisions for them. Yeah.
So, for example, if my mother has dementia,
Mm-hmm.
and she is to the point that she can no longer make decisions for herself, but I want to understand that education piece to help me make decisions, how can that happen if she doesn't have any of the advanced directives and things like that? Can you coach me to help understand and then bring me in as part of the family?
I do that all the time. Yeah. You know, you get people with a dementia that are, you know, they suddenly find that, wow, you know, looking back, she's been in the hospital like 3 times in the past year. And this is going on. Her teeth don't fit anymore. Keep having to buy clothes. She's fallen down some. And a lot of time what I tell people and their families in this instance is, what is this person compared to what they were 6 months ago or 9 months ago? And when they think about it, they're kind of surprised, because a lot of these illnesses are so slow to progress. And if you're seeing them all the time, it's like watching your child grow. You don't see it. You see everybody else's kids suddenly sprouting up inches, but not your own. And it's the same with the disease progression. It's very slow. You're dealing with it day to day. But that's what I do a lot of times with families, is to tell them what it is that's going on, and to also explain that the progression of this disease that they've already seen is going to continue.
So it's almost giving permission for the family to then have a framework for making decisions.
That's exactly it. Yeah, if they know what to expect, they know what their boundaries are, what they would or would not want, and they know that time will come, those decisions are already made. And sometimes, lots of times, that is much less stressful than being faced with a crisis type of thing. If somebody with dementia is aspirating all the time and getting pneumonia all the time, you must put in a feeding tube. No, we've already talked about it. That's not really going to change the course of this disease any. Mom likes to eat. That's the only pleasure that she gets. We know the consequences, and we know what her day-to-day life will be like, and this is what we choose to do.
My father was a family physician, and he always referred to pneumonia as the
Old man's friend. Yep. Yep.
And he also went
Aw.
pneumonia.
Aw. Aw.
And it just empowered all of us as family members who knew that Dad was sick of that.
Yeah. When you know what you would or would not want, and think about it yourself. If you had a stroke suddenly that took you, and you're laying incapacitated in the hospital bed, and this happened with my grandfather. Up to then, he'd been living on his own, doing his thing, had a stroke at Zubu, of all places. And get called to the hospital, what do you want to do? Like, the left part of his brain pretty much is a big blood clot now. He can breathe. He can maintain a heart rate. That's what he can do. What do you want us to do? He can't eat because he's not responsive, but we can put in a feeding tube to keep him alive. Those are the types of decisions that families are asked to make that I help to sort through. And at that time, I thought, for whose benefit would I do that for? Not for his. He will never be the person that he was before. So I have a body to go and visit. Is that fair to him? What dignity does that bring? You know, sometimes these are very difficult conversations, but laying it out like that really helps families to sort through these things and alleviate a lot of guilt that they sometimes feel at having to make these decisions. They're not killing them off. They're allowing nature to take its course. And sometimes that's the kindest thing. I knew what the future would hold for my grandfather if I had said, put in the feeding tube. He'd have been in the nursing home. He'd have probably aspirated some, because sometimes the body, as it is trying to die, forgets to swallow. Things go back up the esophagus. I know that he would have been incontinent, which increases the risk for skin breakdown, certainly. He's not moving on his own, so he certainly would have gotten bed sores. Is that the memory that I wanted of him? No. And nobody else. I didn't wish him dead, but I didn't wish him to be in the state that I knew that he would be in either.
What you're saying.
Exactly.
It's easy.
And have the ability of those follow-up. Currently, no. Sadly, no. You know, this really is something that is going to be pushed by people who realize what it is, just because of the service that it does provide. I know in other areas of the state and the country and things, people like me work just for lawyers' offices who practice elder law. I mean, it's a specialized niche. It's something that really is misunderstood. A lot of people see it as being as synonymous with hospice care, and it really is not. It's an extension of a lot of different entities, but unless you really understand what it can offer and what it can do, I know this part of the state really is behind the times, and my dream is that what you're describing totally will come to pass, because people need that.
It just seems more calming.
There is, unfortunately, and I know that in the past couple of years in Crawford County, this is becoming more accepted. And I'm told that typically Crawford County runs about 10 years behind of other places. Surprise. Yeah.
I live in Crawford, so that's why it's still a love interest, because this is home, but I'm working in Erie. On that same train with Crawford.
They might be a little bit ahead, but I know they still have difficulty in that too. And I know I made a trip to Pittsburgh to Forbes Hospice, Allegheny General, just to get some tips on how to promote an inpatient palliative care program. They tried to do this several years ago, and it fizzled because, as it turned out, the approach was wrong. But you don't know, at that time. But it's growing, and when you think about all of the people living with chronic disease that are being asked to make decisions when they really don't understand, like your person, they get this diagnosis, well, what do you want to do? Well, I don't know. I don't even know what this entails. I don't know how this disease is working, let alone how everything else going on with me is going to act with this, and you're asking me to make decisions. I don't even understand what it is I'm dealing with. How can you be expected to make decisions? And that's what palliative care helps to sort out.
They're mandated.
Yes, they are mandating, because they know in the end, as a financial aside, what I do is present information to families so they can make educated choices. I have no financial interest at all in what people do. I just want to tell you that. However, insurance companies do have a financial interest. And they know when people are making decisions that make the most sense to them, oftentimes it ends up saving the insurance companies money for all the reasons that I outlined before. Unnecessary interventions, shorter stays, less frequent stays, and all of those things. So the insurance companies are very interested in palliative care. As of, was it the beginning of the year, Medicare is going to pay doctors to have these types of discussions with their patients, which is more incentive. Because lots of times physicians are not comfortable dealing with this. It takes some time. As I said, it can take an hour, it can take a while. You need the follow-up, you need a careful explanation on a level that people can understand, but they're going to pay for that. High mark insurance for some groups of their insurance, one Medicare supplement and a couple other things that they have do offer advanced illness services discussions, which really is palliative care. And I really foresee, especially with the baby boomers coming up and that big swell of expense that they're going to incur, insurance companies pretty much are going to mandate that this has to occur, only because you're going to really alleviate a lot of expenses. People undergoing cancer treatments, chemotherapy, radiation, things like that, with palliative care in conjunction, actually live longer because their symptoms are better managed day to day. They have less nausea, they have less pain, they're better able to tolerate the treatments that they would like to attempt. So it really is not a scary thing for people. How can you lose? You're feeling better and you know exactly what it is you're up against.
Even though you're saying it's Medicare related and it's usually for older folks, it's across the lifespan. So for children,
Oh, exactly.
It's for anybody that's just past that is going down that path.
Exactly. We see people, Crawford County Hospice is the only one that sees children and infants. You know, they certainly have a need. Just because you're young doesn't mean you can predict what hand you're going to be dealt.
Next month we're talking about tobacco use and respiratory care education. There's a lot of e-cigarettes coming into our community. People think that maybe it's a healthier alternative to smoking, so we have Paula DeGregory, who is the Northwest Pennsylvania Tobacco Controls Program, speaking. These are typically held on the second Tuesday of every month, but I'm not going to let you take this one because next month Labor Day is on the 7th, which is late, so we need a change from the 8th, which these flyers say, to the 15th. So we'll get that changed, but if you left your email address, we'll send it to you via email. So thank you all for coming, and thank you.